Good morning, everyone. Good morning, Dr. Perera. Myself, Vikas Jaiswal from Endeavor Health Cardiovascular Institute. With me, it is pleasure of mine to have Dr. Divaka Perera from King's College London, who just had a great presentation at ACC 26. The grateful sir.
Thank you for having me, Vikas.
Briefly summarize the trial. What is the key objective of this trial and how it can implement our practice changing in future?
So the background to this is that we know that when patients have poor left ventricular function, and if they need to have revascularization with bypass surgery or PCI, they tend to have very poor outcomes. Their mortality rates are high, and the peri-procedural complication rates are high. And the question that we were asking was, could we reduce that rate of complications by using a microaxial flow pump, so percutaneously inserted through the femoral artery and advanced across the aortic valve into the ventricle? Can we use that up front to reduce the rate of complications or not? That had never been tested in a randomized control trial before.
So also, while going through the presentation today, I observed the key findings were like mortality, which is quite high in the intervention group compared to the standard of care. Can you please shed some light on us?
Yes, so our primary outcome was a composite outcome of death, stroke, spontaneous myocardial infarction, cardiovascular hospitalization, and then peri-procedural MI. But an important difference with our outcome and how we assessed it compared to other trials is that this was hierarchical. So death was far more important than peri-procedural myocardial infarction, for instance. And what we found in relation to the primary outcome was that there was no difference between the two arms. And if anything, the rate of occurrence of those events was higher in the microaxial flow pump. So for the primary outcome, the trial failed to meet its endpoint, and said, which implies that use of this microaxial flow pump is not beneficial. But the secondary outcome that you mentioned was very interesting, which was death, all-cause death, and cardiovascular death. And when we looked at that, we found that patients were more likely to die during follow-up if they were in the microaxial flow pump arm. And most of these deaths were cardiovascular deaths. And when you looked at cardiovascular death, it was twice as likely to happen if you were in the microaxial flow pump arm compared to the standard of care arm. The absolute difference in rate of death was more than 12% at 2 years. So not only did it fail to meet its endpoint in terms of efficacy, but there is a signal of potential harm and safety.
But is it possible, like complexity of the procedures driving these outcomes, like mortality and myocardial injuries in these patients?
We were only interested in recruiting patients who are going to undergo complex PCI. So this wasn't simple PCI. Patients had poor left ventricular function, they had lots of coronary artery disease, and they were undergoing calcium modification in multiple vessels, left main stem PCI, or a CTO with a primary retrograde approach, etc. So this was very complex PCI. And yes, I think the complexity of the PCI is one factor, but the other is that you're starting with a ventricle that's already poor. So you make that ventricle ischemic because of your complex PCI, and it becomes even less able to do what it's meant to do.
It's great. And do you feel like further more investigations needed and with large sample sizes? Oh.
Well, I'm going to answer the two parts of your question separately. I'm going to answer your second part first. There's no issue with sample size here. Sample size is down to the number of events that occur in the trial, and our composite event rate of any one of those outcomes happening was about 75%. So if you look at the total number of patients who had an event, we have plenty of power. We don't need a larger trial in order to answer the question. We have a sort of definitive result in terms of this trial. The first question you asked was, is there more work that needs to be done? Yes. And I think even within our trial, there's a lot more data that we can extract. We need to understand what drove that cardiovascular mortality excess, for instance. We also need to understand why the pump, which is meant to protect the heart, seem to be associated with a greater amount of myocardial injury. And all of this we're going to look at, and we'll hopefully be able to share with you and the rest of the community in the next few months.
Thank you, sir.